reveal any rectal perforation. So given the findings on the posterior vagina, GYN was consulted intraoperatively to come take a look. And it was noted that there was inflamed and necrotic appearing tissue in the posterior cul-de-sac extending over the uterosacral ligaments bilaterally. A digital exam was done, and at this point, a 2 to 3 centimeter defect was noted between the uterosacral ligaments extending into the vaginal vault, similar to a posterior colpotomy. And GYN-ONC was consulted to repair this vaginal defect. Laparoscopically, the tissue was too necrotic and inflamed and tore with placement of suture. So then defect was repaired vaginally. Post-operatively, she did well. There was a JP drain placed intra-op that had serosanguinous output. She was discharged with augmentin and flagyl for 14 days, and the JP drain was removed in the week, like the follow-up appointment in a week. And she was recommended for 10 weeks of pelvic rest. And she had another post-op appointment at 5 weeks, where a speculum exam was done with intact posterior aspect of the cervix with suture still visible, no erythema or discharge, with scant granulation tissue around the healing defect. And on bimanual exam, posterior aspect of the vagina was still intact without defect. And she was recommended for additional 8 weeks of pelvic rest given what had just happened. So for this case, I thought it was just an interesting case with a lot of things that occurred. And I wanted to point out potential areas for improvement and potential causes of defect, of the vaginal defect. So for potential areas for improvement, first on the initial speculum and bimanual exam, the defect was not noted. Um, so that's something that could have potentially been found at that time. But given that she's 16 years old and was very uncomfortable, the exam might have been limited because of that. However, the ultrasound and the CT finding with the free air was also done after the exam had already happened. So once that finding was known, it might have been a good idea to repeat the pelvic exam when there was no really clear source of the air, based on the fact that her abdominal exam was also pretty benign. Um, and I also wanted to note that residual pneumoperitoneum usually resolves in 3 days in 80% of patients and 7 days in 95% of patients. So perhaps she could have been taken to the OR sooner instead of repeating the abdominal X-ray and then keeping her till the following day as well to do another abdominal X-ray when the CT and the first abdominal X-ray showed that there was already persistent air. And then in terms of the potential causes of defect, I think one possibility is that during the endometriosis surgery, the tissue was weakened from the dissection that was done. And then on top of that, she had formed intra-abdominal or pelvic infection that was already happening before the sexual intercourse because she actually was having pain prior. And then in addition to that, having the sexual intercourse might have weakened that tissue. Okay, that's it. Thank you.
All right. Thank you, Ray. With 1 minute left, does anyone have any questions? All right. Well, then let's just leave it at that. So thank you, Ray.
Thank you.
Well, it's time now to transition into grand rounds. In just a moment, I'm going to ask Dr. Saluki to introduce our grand round speaker. But in the meantime, I'm asking everyone, please, please, for the sake of our administrative team, when you log on to a Zoom or a WebEx, look and see how your name is displayed. And since we're almost always taking attendance, see if we can tell who you are from your name. If you have a very unique first name like Madonna or Cher, then I guess it would be okay for you to use your first name only. But otherwise, it would be very helpful if you gave us your last name. Also, if all you see appearing is your device name, it would be very helpful if you would give us your name, and you can send that to us in the chat, or you can email Michelle or Beth or I, or if you're a student, you can send it to Millie. So with that, Dr. Saluki, are you ready to introduce our speaker?
Yes, can you hear me?
Yes, loud and clear.
Okay, good, because my connection was a little patchy earlier on. Okay, good morning again. Second week in a row. Good morning, colleagues. It is my great pleasure to introduce my longtime friend, former schoolmate, former co-resident colleague, Dr. Moti Gulersen, to present on the topic of antenatal steroids at this morning's grand rounds. Me and Dr. Gulersen have known each other since our medical school days at Technion in Israel, where Dr. Gulersen graduated at his classes as his classes valedictorian, and also had the honor and the pleasure of being his co-resident during our OBGYN residency at Northwell's Lenox Hill. After residency, he completed his MFM fellowship at Hofstra's Medical School North Shore LIJ hospitals. And currently, he's the MFM faculty at the Sidney Kimmel Medical College of Thomas Jefferson University in Philly, where he serves as the director of outpatient operations and preterm birth prevention program. His research interests include antenatal corticosteroids, prediction and prevention of preterm birth, induction of labor, and the list goes on and on. And although he's relatively earlier on in his career, he's already co-authored over 60 manuscripts, over 100 abstracts. I have no doubt you're going to be hearing more and more about him. He is currently the lead PI for a multi-center randomized controlled trial evaluating the utility of cervical cerclage in patients with a short cervix at 24 to 26 weeks of gestation. And I have a feeling he's going to come back to our Grand Round series to present on this topic by popular demand. On a more personal note, Dr. Gulersen is one of the brightest, most inquisitive people and physicians that I know. In our residency, Moti was known as a human OBGYN journal Yelp. That's how I would refer to him, maybe privately. He was able to cite Green Journal abstracts hot off the press before they're even printed out, I would say. I have no doubt that everyone attending today will be able to take something away from this presentation. So definitely tune in. He's an engaging speaker and a gifted teacher. And with that, Dr. Gulersen, thank you so much for joining us today, and I yield the mic to you.
Wow, thank you so much, Shirley, for that excellent introduction. You're making me blush for sure. I'm going to pull up my slides. Hopefully you can see them. Are you able to see the slides?
Yes.
All right. So yeah, again, I'm really honored to be here, and thank you so much for the opportunity. The title of today's talk is Updates in the Use of Antenatal Corticosteroids. Quite the hot topic and controversial these days. Can you see my cursor as well? I just want to make sure.
Yes.
Okay, perfect. So I have nothing to disclose except that I'm obviously very excited and happy to be here today. So all of us I'm sure, are quite familiar that it's been over 50 years since the landmark trial by Liggins and Howie, which demonstrated that the use of betamethasone in patients at risk of preterm birth significantly reduced the risk of neonatal respiratory distress syndrome. And since then, what we describe as antenatal corticosteroids, which is either betamethasone 12 milligrams, 2 doses 24 hours apart, or dexamethasone 6 milligrams, 4 doses every 6 hours, has really been one of the most important antenatal therapies, if not the most important antenatal therapy that we have to reduce the risk of neonatal morbidity mortality in patients at risk of preterm birth. Despite, though, over 50 years of research in this field, there's still a lot of questions that remain, particularly related to the use of gestational age administration, as this kind of has expanded over time. The timing, the dose, the type of setting that we administer antenatal corticosteroids, and a lot of questions certainly recently have been surrounded related to the long-term impact of its use in pregnancy. So I wanted to focus first on gestational age at administration, really focusing on two periods. The one, the late preterm period, which we're all familiar with, is described as 34 to 36 and 6, and we'll talk about both singletons and twins, and the pre-viable slash peri-viable period is certainly a topic that as well is emerging with some evidence related to antenatal corticosteroid administration as early as between the range of 20 to 23 and 6 weeks. So focusing on, late preterm steroids, the ALPS trial, which I'm sure we're all familiar with, was a landmark trial investigating the use of, betamethasone antenatal corticosteroids in patients at risk of late preterm. This was an MFMU trial in the United States, which really demonstrated that the use of betamethasone in patients at risk of late preterm birth significantly reduced the risk of a composite outcome that mainly included, respiratory morbidities related to CPAP, or the amount of oxygen you expire by the neonate. And not only was there a significant difference in the primary outcome, there was also a significant difference in severe respiratory complications. And a lot of that, was driven, by the significant difference in TTN as we know it, as you can see here. When we think about most, the prematurity related complications that are more common in earlier preterm birth, like respiratory distress syndrome, the likelihood of that occurring in the late preterm period is lower. And that's evidenced by this no significant difference seen in this trial related to late preterm steroids. Another, common long-term complication that we think about, BPD, was significantly different, although you can see that the numbers were quite small. So certainly benefit in reduction of the risk of respiratory complications after late preterm delivery. There were only 2 neonatal deaths in the cohort, so that there was no significant difference between those two. And as we know, and as one of the outcomes that was found to be significantly increased in those exposed to betamethasone was hypoglycemia. So we know that based on the findings of the ALPS trial, there were certainly significant benefits related to neonatal respiratory complications, and that was independent of gestational age or randomization, although there was a significantly increased risk of hypoglycemia in those that got steroids. There really were no adverse events related to hypoglycemia, and in fact, prolonged NICU stays were actually lower in those that got antenatal corticosteroids. As mentioned, there were no cases of stillbirth or neonatal death less than 72 hours after birth. An important caveat for the ALPS trial is that patients with pregestational diabetes and multiple gestations were excluded. So, reviewing, that this is the trial that ultimately really changed practice. And when this trial was introduced into a Cochrane review, along with other trials evaluating late preterm steroids, we found, they found that, of course, this demonstrated a significant reduction in the risk of respiratory distress syndrome. So again, ALPS trial gets published, really changes practice, certainly around the United States. An updated Cochrane analysis incorporates the ALPS trial into the existing evidence. And then, overall, we're noticing, okay, this is clearly an intervention that's effective, has benefit. So, a lot of, it was adopted really around the world initially. But still, despite, level 1 evidence based on the Cochrane analysis demonstrating, a benefit in late preterm steroids, clinicians were still encouraged to kind of balance the known benefit with an uncertain long-term risk because of the potential evidence related to the long-term impact of antenatal corticosteroids. But I want to kind of touch on, this is not something that is unknown in obstetrics. Think about it. We are giving oxytocin. Do we have a lot of long-term data related to that? We use this daily. Not much. Misoprostol, progesterone, the tocolictus that we're administering. So I think that as obstetricians, we're often encountering this dilemma when we're thinking about any intervention that we give. We know that there's going to be benefits in the short-term period, but the long-term risk is something that needs to really be studied because it's something that we see commonly in almost all of our interventions. And then that's when, a lot of publications really started to emerge relating to the long-term impact. There were animal studies suggesting that steroids, modulates the brain, especially in the late preterm period when there's an acceleration in the brain maturity. There was a bunch of systematic reviews outlining that, oh, okay, you know what? Antenatal corticosteroid exposure in the late preterm period, especially among those that deliver at term, may be associated with a higher likelihood of psychological, developmental, and neurosensory disorders. So certainly a lot of observational studies really created this controversy related to really balancing the risks of benefits with potential long-term risks. But what's important when, considering these, long-term data that have been published in these meta-analyses in really, reputable journals. Well, there are no randomized control trials at that time that had evaluated that, and there were several unknowns related to the studies that were included, meaning the gestational age of antenatal corticosteroid administration was unknown in each of those studies. So it's possible that someone had got it at 25 weeks and then delivered at term, or 36 weeks and delivered at term. Those are potentially different patient populations. The indication for administration or other antenatal complications that may independently influence the risk of neurological impairment was not included. For example, we know that babies born with fetal growth restriction are at higher risk. If you're not potentially stratifying by that, then that could potentially introduce a confounding bias. Incidence of hypoglycemia was not reported because that can potentially impact the long-term risk, and really the severity of childhood disease was not included. Furthermore, most of these studies excluded fetal or neonatal demise. And, why is this important? Well, the administration of steroids increases the likelihood of survival. So among those so if you're going to have a higher percentage of proportion of patients that are surviving, those that are surviving still will be at high, there'll be more morbidity potentially among those survivors, and that can also cause some bias as well. So, certainly important to evaluate long-term data, observational. Certainly this was really important data that emerged and, helped us to contemplate what are the balance of risks. And then that's when the long-term follow-up study, which was presented at SMFM last year from ALPS, emerged and found that using this general tool that is validated for evaluating neurodevelopmental outcomes or later in life, there was no significant difference among those that were exposed to late preterm steroids compared to placebo. So important, we've had observational data that have suggested that there potentially could be harm related to late preterm antenatal corticosteroid exposure. Then ALPS subsequently publishes their long-term data that demonstrates that there was no significant difference. But it's important to realize that among those over 2,000 people that were eligible, only 949 were included. So again, further highlighting how difficult it can be to do follow-up studies for randomized control trials. As well, there was COVID that may have impacted that as well. But still, we had these data that showed no difference. Only 160 of those were born at term, and a lot of the emerging data from the observational studies had mentioned that those that were born at term but exposed to late preterm steroids were really the particular population that was at highest risk. But nevertheless, this was the largest follow-up study of a single course of antenatal corticosteroids. So again, important to acknowledge that this is level 1 evidence, long-term, and this is probably the best data that we have. Still can be, of course, difficult to disengage like millions of patients that were included in those observational data that I had mentioned previously. So what has happened since ALPS? Well, during the time, which is not uncommon, is other countries and other places around the world were conducting similar trials to determine whether it's of benefit. And there were 2 particular trials that were conducted in India. One was demonstrated here that showed, evaluating the use of late preterm steroids in patients at risk of preterm birth. And they actually adopted a very similar primary composite outcome to ALPS. And unfortunately, that was a negative study. There was another trial done using dexamethasone, not betamethasone, by the World Health Organization. And that was evaluating the use of dexamethasone for patients at risk of preterm birth. Important to note for this trial was that the primary outcome didn't necessarily include those respiratory morbidities that you saw in the other Indian trial or the trial that was done by ALPS. In low resource settings, you typically see more significant outcomes included in the primary outcome, which included neonatal death, severe respiratory distress, and et cetera. And again, that's not an uncommon finding when you're evaluating the utility of interventions in lower resource settings. And unfortunately, that also was a negative study. Both of these studies were also stopped early due to either futility or a lower than expected incidence of primary outcomes. Both of the studies also included twins. Although it was a low percent proportion of twins, at that time, we didn't necessarily know what was the impact and whether there was any benefit of late preterm steroids in twins. Remember, ALPS included only singletons. There was a higher proportion of term deliveries in both of those trials compared to the ALPS trial, which kind of, again, highlights that, you know, when you have a randomized control trial and you're having strict inclusion criteria, if those criteria may be different, you might be, you know, it highlights the potential poor timing that we have with antenatal corticosteroids. And again, if you have a higher proportion of term deliveries, then those outcomes may be less frequent because those babies typically do well. The patient populations were quite different. Again, the resource settings, which is an important thing to highlight whenever you're evaluating interventions in obstetrics, you know, are different. We may not have the neonate, the studies in India, for example, they may not have had the availability of the neonatology providers immediately to administer the oxygen, et cetera, things like that, that have been potentially implicated in healthcare environment as well. So, you know, ALPS comes out, subsequent randomized trials that evaluated kind of similar outcomes, demonstrated no benefit. So again, important to highlight some of the newer data that emerged. Now, this was when we're thinking about twins, because all the data I previously presented were predominantly singletons, this was an abstract that was presented just this year at SMFM, a multi-center trial done in Korea, evaluating the utility of late preterm steroids in twins, particularly, and only twins at risk of late preterm birth, also demonstrated that there was a potential benefit in terms of reducing the risk of their primary composite outcome, which again mainly included CPAP for greater than 12 hours. So we had level 1 evidence emerging, suggesting benefit in singletons. Now we're, you know, seeing evidence supporting the use in twins, although this has not been published yet. So it's important to realize that I'm really anticipating, looking forward to the publication related to this, but it's very possible that and I'll be interested to hear about your institution, if you're already administering in twins, you know, this might become standard of care after publication of this trial. So where do we stand now? You know, who recommends late preterm steroids in singletons? We know that ACOG and SMFM do, but that's pretty much about it. You know, the Royal College of OBGYN, you know, recommends it up until 34 and 6. A lot of, you know, well-known, you know, societies are not recommending, as you can see, the World Health Organization, FIGO, our colleagues up in Canada. So there's clearly, you know, a disconnect right now among professional societies related to late preterm steroids. And, you know, I'm anticipating more and more updates, especially as more and more data is emerging. And then for ACOG and SMFM, you know, currently, based on the committee opinion that we have, or the consult series for late preterm steroids, it does allow us to use shared decision-making for twins. And I think here at Jefferson, initially, we were not administering it for twins, but now with the recent, you know, presentation of the study from Korea and, you know, acknowledging shared decision-making by ACOG and SMFM, that we're incorporating it more and more into our practice, especially, you know, for those that are planned deliveries in the preterm period. I wanted to touch base on this recent publication that could be really helpful, because a lot of, you know, a lot of our colleagues are potentially starting to, despite publication of ALPS, you know, some may say, oh, you know what, I don't know if I'm going to give it at 36 weeks, maybe because of that, even though there was it was independent of gestational age. There was a subgroup analysis from ALPS that said that it was similar at 36 weeks, those outcomes, but it was underpowered. So some providers might say, oh, you know what, maybe I think I'm going to offer it more to 34 and 35 weeks versus 36 weeks. how can we counsel our patients? You know, if ALPS was particularly a grouped of 3 weeks of gestational age. Well, this was a secondary analysis that was recently published that utilized the data from ALPS and incorporated into a model to really help with our counseling for patients based on mode of delivery and gestational age at delivery. So for example, you know, we just had a vasa previa that was scheduled for delivery at 36 weeks. Vasa previa, we deliver via cesarean section. So you can pull this, and I've done this before. I've gone on rounds and I've pulled up this figure and I've spoken to the patient. I said, okay, we're planning for delivery at 36 weeks via C-section. The risk of respiratory complication is going to be 12.9% if there is no administration of late preterm steroids. If we do give steroids, that risk gets reduced by about 2.5% to 10.6%. It's a statistically significant reduction, but that's the magnitude of effect. A patient might say, you know, and then you counsel them on the potential long-term risk, the limitations of observational data, the fact that we have long-term data from ALPS that has demonstrated, you know, no harm. A patient might say, you know what, 36 weeks, that reduction is 3%, 2.5%. I don't know if I'm okay and I'm willing to accept that 2.5%, which is overall low even at that gestational age, for the potential risk of unknowns with long-term data, even though that ALPS long-term follow-up was negative. And what you can see, so I've had patients that after informed counseling, they say, you know what, I'm going to, you know, at 36 weeks, I'd prefer to not have steroids. But if you can look, you know, the magnitude of effect is much greater at earlier gestational ages. So if you tell a patient even at 34 weeks, whether it's a planned vaginal or planned C-section, those risks are higher. The magnitude is a bit more significant in terms of its difference. They might be willing to accept and, you know, steroids, et cetera. So I think this is and they also included a table related to severe respiratory morbidity. This was a primary outcome. So I think it's really helpful in patient counseling, even though this is a model of the ALPS data, to say, based on gestational age and planned mode of delivery, even though it's significant across all gestational ages, that magnitude of effect is different, and that might potentially impact their decision on whether to proceed with antenatal corticosteroids. So I think this is a really, really helpful, and this was, you know, published in the Green recently. Could be a really useful tool for patient counseling. In terms of future research, you know, we submitted an updated meta-analysis that we're hopefully pending for publication that's evaluated and incorporated the trials from India. And another thing that we're noticing with systematic reviews, what's really important nowadays is you know, trustworthiness in randomized trials. So you know, more and more tools are emerging to help stratify and kind of weed out the randomized trials that may not be as trustworthy. So, you know, we submitted this and hopefully will be published soon. We need some more long-term data and, you know, multiple gestations and pregestational diabetes. We talked about the data from Korea related to multiple gestations that have emerged, that have shown benefit. What do we do about patients with pregestational diabetes? There have been data to suggest that actually around the United States, using live birth certificates, that patients are even getting it despite their exclusion from ALPS. What do we do about fetal anomalies or those that are expected to deliver within 12 hours? Another couple of patient populations that we need more data on. Now I wanted to switch gears to the other extreme of preterm, and that's related to the previable period. And this was a publication in 2017 that demonstrated that a baby that was born at 21 weeks and 4 days gestation survived. So clearly, with our advances in our neonatal technology, our interventions, our et cetera, we're seeing more and more babies being delivered at and surviving at such extreme early preterm periods, highlighting the importance of use of steroids in research amongst this patient population. And so what happened in 2013, you know, the NIH, SMFM, American Academy of Pediatrics, and ACOG, they had a joint workshop in periviable birth, and they, you know, recommended at that time administration at 23 weeks in patients at increased risk. And that was based on a multi-center observational cohort from the United States that showed that antenatal corticosteroid administration exposure, among infants born at 23 weeks was associated with lower odds of, you know, death and neurodevelopmental impairment. So clearly an effective intervention at 23 weeks. And as a result, in 2017, ACOG and SMFM updated and created their obstetric care consensus, which mentioned to consider steroids at 23 weeks, which I'm sure most of us are doing nowadays. But what about 22 weeks? Well, in that study that was shown in multi-center observational cohort, only 119 of those were exposed at 22 weeks. So since then, there have certainly been more and more data that have emerged, and particularly this one systematic review and meta-analysis that was published recently in AJOG that looked at a 20-year span of infants born at 22 to 22 and 6 among those who received proactive treatment, which is important to mention when you're evaluating intervention to help reduce the risk of neonatal complications. And those outcomes were related to either any of the intubation, face mask ventilation, use of CPAP, compressions, or epinephrine administration. Important to highlight that fetal demise, stillbirth, and these congenital chromosomal abnormalities were excluded. And initially, actually, this was primarily done to just quantify prognosis, to help, with our neonatology colleagues to give data on what is the likelihood of survival, what is the likelihood of survival with, severe morbidity, et cetera. But there were outcomes based on antenatal corticosteroids. So that was what was evaluated, and particularly in this study. And it showed, with the inclusion of 31 studies, which were majority case series, that antenatal corticosteroid administration exposure at 22 to 22 and 6 doubled the chance of survival from 19.5% to 39%. So clearly an effective intervention. Now, acknowledging that in some of these studies, it's difficult, there's a selection bias. You might be giving antenatal corticosteroids more commonly to patients who you feel are maybe more likely to survive. For example, so maybe someone who doesn't have severe FGR at that time, et cetera. So there's certainly a lot of, potential confounders. Nevertheless, this showed that this was effective in improving survival. But again, what's important when you're counseling these patients is that despite survival improving at that early gestational age, there is still significant morbidity that is occurring among those survivors. And that's, related to the pooled prevalence that you can see here of bronchopulmonary dysplasia and intraventricular hemorrhage. These are high numbers, very high numbers. So among those that survive, there's still a high risk of morbidity. And based on this, ACOG updated their consensus and suggested that you may be considering steroids at 22 weeks to 22 and 6. So I'd be interested to hear what happens at Robert Wood Johnson related to this as well. Whether or not we should be doing it to 20 to 21 and 6 still remains, unclear. I will say at Jefferson, our peri-viable guideline, we've included as early as 21 and 5 with the anticipation of delivery at 22 weeks as candidates for antenatal corticosteroid administration. For example, that P-primer that comes in. So we've done that. Always an interesting discussion. So we look forward to hear what's going on at Robert Wood. And then since that publication of the systematic review meta-analysis, a number of more studies have emerged, potentially showing benefit of steroids at this gestational age. So clearly an intervention that is really expanded, because when we're thinking about Liggins and Howe, it was 24 to 36 weeks. Now, 34 to 37 has really become more and more popular amongst the research, and now even before 24 weeks. So we've really expanded the gestational age of giving steroids in our patients at risk of preterm birth. So for those in the pre-viable period, although rates of survival are increased, there's still major neonatal morbidity that is important for part of counseling. We always want to incorporate our NICU colleagues, and shared decision-making really important as well, incorporating patient preferences and availability of resources to perform resuscitation and support. Nevertheless, of course, like everything in research, we always need more data. So we'll look forward to seeing that. I wanted to switch gears to a passionate topic of mine related to steroids. That's, again, a controversial, is really related to the timing of steroids. We know that the optimal time interval for steroid administration is within 2 to 7 days, delivery within 2 to 7 days of, after administration. And that extends to the late preterm period based on some recent evidence that we published. However, despite that, our optimal timing is really poor, as low as 10% in some studies, as high as 50% in others. And these are emerging really based on data that evaluating patients at risk of spontaneous preterm birth, not necessarily medically indicated preterm birth. So why are we so bad? What's the main reason? And really the main reason is we're just really, unfortunately, bad at predicting preterm birth. So this is really allows for, or what's happening is that more and more patients are getting unnecessary exposure because of how poor we are at predicting preterm birth. And so I've looked at this, is this something, can we make a calculator? That would be, I think, the most interesting thing. A lot of studies that I've listed here have looked at what are predictors potentially of delivery within 7 days. And certainly there are a number of predictors that have been included in these studies. P-prom, nulliparity, or age, smoking, prolapse membranes. There's also been apps and that have been developed from the UK that incorporates quantitative fetal fibronectin. I would be interested to hear, but we in the United States are not really using quantitative fetal fibronectin at all. Qualitative is still even not many centers are using that. So there have been studies that have identified predictors at high risk, that are associated with a higher likelihood of delivery. So I've always thought to myself, can we make a calculator? Can you take that patient who comes to triage, plug in their information, what's their age, what's using the ones that have been identified as predictors and candidate predictors of preterm birth, can we incorporate that and just plug it in and say, okay, this patient, Jane Doe comes in, this is her presentation. Okay, 10% likelihood that she delivers in 1 week, for example. Controversial whether to include race and ethnicity, even though we know that there's, disparities amongst preterm birth prevalence that doesn't necessarily relate. That's more so related to, institutional structural racism rather than any biological impact. Cervical lengths, not everyone's doing it up to a certain gestational age or fetal fibronectin. But nevertheless, I'm really trying to work hard on, we're doing some research now, systematic reviews, and I'm trying to find databases to create a calculator that potentially can help with counseling. The challenge, though, is what's an acceptable risk cutoff? So let's say Jane Doe comes, she's 32 weeks, you put in her information, she has a 20% risk of delivering within 1 week. Is that a risk? That's a pretty high risk. Maybe I'll give steroids to that patient. Is it 10% that we should say not to give steroids, or is it 5%? There have been studies that have looked at, especially the UK studies with their apps, that apparently 5% could be a potential risk threshold to avoid any unnecessary exposure and even hospital admission. It's really not clear what's the most acceptable risk cutoff, but something to think about. Another thing is, the assessment of risk is really based on variables at the time of admission. So let's say Jane Doe comes in, she's contracting, she's 2 centimeters, she's in pain. We're putting all of her information, but then you're going to check her 2 hours or 4 hours later. What if her cervix has not changed? Can we use that data as well to potentially allow and guide us for our steroid decision making? And, so that's, I think, is something that's interesting. And what about medically indicated preterm births? Not much data. I'm looking at hypertensive disorders of FGR. We've presented an abstract at SMFM related to timing with FGR and the likelihood of optimal timing in those pregnancies, even though most of them make it to term, is quite low. So I'm working, and I'd be interested to hear if anyone has any other thoughts on, prospective studies. What are the good databases that we can use? Essentially, that's probably the only way we might be able to do it is, and, I'm looking to obtain funding related to that. So another thing that is important to address when we're thinking about recent updates in antenatal corticosteroids is related to the dose. So the standard betamethasone regimen was really initially derived from animal studies that were preceding the 1972 publication. And that was just that was it, 12 milligrams, 24 hours apart, over 50 years ago. We've had some accumulating evidence that more and more repeated doses, right? We used to give steroids every week to patients, and we knew that that was harmful. And so there could be a potential dose-related effect of steroids. So that's what's prompted recent studies to look at whether or not a lower dose can maintain similar efficacy while minimizing potential harm. And so there were some animal studies, just like we do in medicine, trying translational research. Let's evaluate and investigate this in animal studies, showing that potentially a lower dose of the steroid regimen can potentially be equally as effective in preterm sheep. And this was done in both these publications. So certainly animal studies have suggested that potentially you can have a similar efficacy when you're thinking about a lower dose of betamethasone. And then ultimately, this led to a very large multi-center randomized trial from France called the beta dose trial. And this was now the first time in over 50 years that in humans, the betamethasone regimen was challenged. And so, humongous effort by our colleagues over there to conduct this trial. This was in the inclusion criteria were singletons who received the first dose of betamethasone less than 32 weeks were eligible for inclusion, then randomized to either a second dose or placebo. And their primary outcome was intratracheal surfactant administration within 48 hours after birth. This was also presented at SMFM as well. And the difference in primary outcome between the two groups was 2.4%. So 20% in the half dose group, 17.5% in the full dose group, and that did not meet criteria for non-inferiority. So meaning that it's not, that half dose is non-inferior is not going to be as effective as the full dose. Important to highlight, though, no differences in neonatal mortality or prematurity-related complications between the two groups. Of course, highlighting an issue that we just talked about earlier is the likelihood of delivery within 7 days of steroid administration was 16.8%. Again, another just number to suggest clearly we're poor at predicting preterm birth, and we need to be better at administering steroids in those that are needed. And what's interesting is the benefits of full dose may have been underestimated, because what happened was among those who delivered within 7 days or among those who delivered less than 32 weeks, that magnitude of effect between the half dose and full dose was much more significant, further highlighting that, okay, this is suggesting that we should continue our 12 milligrams 24 hours apart, or dexamethasone, which was not necessarily evaluated in this trial. So again, highlighting that the full dose is what we should be continuing to do. And, potentially whether it's just 12 milligrams once, some people have suggested maybe betamethasone cutting it, to maybe 6 milligrams every 12 hours for 24 hours of betamethasone. Maybe that potentially could be something else that is investigated in the future. I think this is also a common scenario that you might encounter on antepartum. What if you have a patient who comes in preterm labor at 30 weeks, you give steroids, she's advancing quickly, and 12 hours comes by and you're thinking to yourself, should you give the second dose sooner? So this was a meta-analysis that we just published looking at randomized trials that compared the 12-hour interval, which is the 24-hour interval for betamethasone. And, unfortunately, only 2 randomized trials were included. One we had to exclude because of trustworthiness, and suggested that there may be some benefit in a reduction of the admission to NICU and a reduction in the administration of surfactant. So, historically, there had been only one trial that was done. Now we've had a second trial. And so combining the two suggests that there may be benefits. So certainly something you can consider if you're having a patient on antepartum where you're anticipating delivery sooner than 24 hours. Certainly reasonable to consider, again, administration of that second dose at 12 hours versus 24 hours. So what now? I think important whenever you're thinking about steroids in any sense is really appropriate counseling. I remember when I was a resident, when we were talking about steroids, we never even talked about long-term data. That was never even part of the, we used to say, what is the only risk of steroid administration? Pain with the injection. The benefit was certainly significant. So regardless of gestational age, I think counseling has to really incorporate every variable, even including potentially long-term, especially in the late preterm period. Obviously need to optimize timing to reduce unnecessary exposure. Developing preterm prediction models. Could we use AI? I think there needs to be a push to try and do that. And I've been working hard, speaking with many people on how can we do that. Potentially, we do. If you're going to use AI, you need a robust database. Unfortunately, when you're looking at some of these databases, the granularity of what happened at the time of antenatal corticosteroid administration, it's difficult to really obtain all those data related to cervical dilation, et cetera. So it's really important. We need more long-term data. And how important is gestational age? And I think that is certainly important. So remember, I was talking about potentially is there a risk cutoff for the use of steroids where you'd say yes or no? Well, if I told you a patient had a 15% risk of delivering within 7 days who presents at 32 weeks versus someone who presents at 23 weeks has a 15% risk, a provider might say any risk at 23 weeks of delivery within 7 days is enough for me to give steroids, because what if they do deliver? it's such an important therapy to reduce the risk of, to improve survival. So I think we should be better at potentially stratifying gestational age in our decision making. What prediction related to that. So I guess I did finish a little bit early, but I just want to thank everyone for this opportunity. This was a review that I wrote with Cynthia that is published online. It kind of talks a lot about what I talked about in this lecture today that is available for anyone to review. And I welcome, of course, any questions, because I know that this is a really interesting and controversial topic. I'd like to hear more about, again, what you guys are doing, et cetera. And again, thanks so much for the opportunity.
Dr. Gulersen, thank you so much for this review. You were talking about the 2 Indian studies being negative studies. Was that negative for improvement in neonatal respiratory outcomes, or was that they didn't show adverse behavioral outcomes later on?
Yeah, so the 2 trials, one was looking at neonatal respiratory morbidities, and that was stopped early due to futility. And then, so those were all like immediate, not long-term. And then they are planning a long-term follow-up, but we're anticipating those data. And then the World Health Organization trial looked at a composite outcome that included more severe significant outcomes, severe respiratory distress, death, et cetera. And that was stopped early because of just poor patient recruitment. So both of those trials from India were really looking at neonatal outcomes rather than long-term outcomes.
Thank you. I see that Dr. Saluki has her hand up.
This was such a great talk. Oops, sorry, I have 2 screens now. And it's one of my babies, Moti.
I know.
So, yeah. So my question is, and I'm a urogynecologist, as you know, so I haven't had to make those decisions or have those discussions with patients. Is there any data or studies on like administering and I'm sure there have been in the past, just like more doses. I know that in residency, like we occasionally did that in patients who presented in preterm labor and then like were okay and then came back again preterm labor later on. And so what's the data on that on like repeat doses?
So the what we do now, I mean, historically, and I'm sure some of the people on this call who knew that you used to give it multiple doses, like more than 2. And there was a couple of randomized trials that have evaluated that and showed harm, lower birth weight, smaller head circumference. So we definitely don't give more than 2 courses, but we know that a rescue course, as demonstrated by the Garidi obstetrics trial that was published in AJAR, I think over 10 years ago, showed that in patients that are at risk of preterm birth who had already received a course at least 7 days prior are still candidates for a rescue course. So no more than 2 courses. But even just to suggest, we talk about timing, when you do admit there's been data looking at this, even when you do a rescue dose, your timing is still poor. You'd think that if you have a rescue dose that you're going to be better with timing, but it's still poor. So right now, no more than 2 courses. Yeah.
Thank you. I see that Dr. Rosen has his hand up.
Hey, Dr. Gulersen, thanks so much for your presentation. I'm guessing from your presentation that you guys do follow the ALP protocol and give late preterm steroids. Is that correct?
That is correct, but I will admit that amongst even our MFM division, and Dr. Burgell and I have this conversation almost every day, there's certainly some, disconnect related to which patient at which gestational age are the candidates. So 36 and 4, some of our MFM providers may not feel strongly about steroids. So,
Yeah, it's funny. It's like hard to dissect it out that finely with a lack of data. So those kind of conversations always are a bit frustrating for me when I hear them. There's a couple things that have led us at Rutgers not to give steroids preterm, like these result of policy. I believe about a third of medical centers in the U.S. have opted to get, or RPCs have opted to get steroids. I think that's about the right number. One thing that I don't think, when you talk about whether there's long-term harm, and going to those Finnish and Danish studies that have shown, the big population studies that show long-term harm, it's not insignificant. Like if you look at the cognitive and behavioral disabilities in children at like age 8 or age 10, the population incidence is about 4 or 5%. In women who delivered their babies at term but didn't get steroids, and it almost doubles, like to 8 to 9%. So that's a big risk. I mean, it's a big wastebasket diagnosis. And then you have to ask the question, is there biological plausibility? So I was like kind of took a little bit of an issue, and hopefully I can challenge you a tiny bit without being offensive. But when you talk about Pitocin or you talk about prostaglandins not showing, there being an unknown about whether there's long-term risk. You have to think about mechanism of action of the agent that you're using, and one of the main ways that steroids have their the way they work is by causing epigenetic changes, right? And so there's definitely a plausibility that when you give steroids, even one dose, and you permanently change the way genes function, you can see that effect that's been documented in those big population studies. One last thing about why we don't use the long-term steroids is even though that you're happy to see the long-term ALPS data showing no harm. One thing I really worry about is that they didn't give the long-term follow-up. It's great that they spend a little bit less time on oxygen in the NICU, which is the primary benefit of ALPS. But 5 years out, when they were studying neurobehavioral outcomes, they should have given a respiratory data as well. Were these kids having fewer episodes of pneumonia or were they in any way unhealthier than children who get the steroids? So with no long-term harm or really a lot of data saying long-term harm and no data showing the long-term benefit, that's why we've made our call not to give the steroids. Do you think we're doing the wrong thing?
Well, so you're saying that anyone at 34 weeks or later is not getting steroids at Robert Wood?
That's correct.
Okay, yeah. No, I mean, I think first of all, your point about the mechanism of action is extremely important, and I agree. I just wanted to kind of stimulate the discussion related to the unknowns of long-term in general. There's certainly animal studies that have showed, important programming, like the mechanism of action, like we talked about. So certainly that's been someone's, that's been a lot of people's concern. Also related to, some people have said CPAP for 12 hours. Is that really a good, how significant is that? And I've talked to Cynthia directly, and I've talked to sometimes neonatologists as well. If you're on CPAP, you can't feed. And so then you're getting IVs, et cetera. So that, but I think I definitely don't think you're doing the wrong thing. I just think that it's important to just, work with the data that we're having. You're right. It's impossible to ignore the millions of patients that have been included in those observational studies. And that was, what was written in the letter to the editor too, based on that long-term study. So I think just, it's really a matter, I think really the patients should be making the decision. And I think that if we do appropriate counseling, then I think that could help too.
Yeah, shared decision making is always super important. That's a tough one to bring to your patient. So are you going to 12 hours, you have to go through that short-term benefit versus, well, maybe not. There's a risk that your child will be in a special school or might be diagnosed with autism. And it's all how you present it too. There was some biases, there's bias in how we all present things. And one of the biases when you were talking about the negative studies about late-term steroids, you used the word unfortunately. And so even that little thing, I bet you that if you counsel the patient, they would be much more likely to take the steroids at 35 weeks than if I counsel the patient, and they would be much less cycling. There's a lot of bias in what we counsel. So I don't think that's a solution either. Thanks so much for presenting a very comprehensive review of the controversial topic of steroids. And it goes to the fact that MFMs will never find that we can't debate something, right? Even though this has been around for 50 years or 70 years, we're still debating it. So thanks again.
Yeah, thank you.
I see that Dr. Sharma has her hand up.
Hey, Ruchira.
Hi there, Moti. I'm just so excited to see you. So for everyone who doesn't know, Dr. Gulersen was my junior fellow, and as always, outstanding presentation, such a beautiful thought-provoking talk. So I was going to say a little bit about just informing you what we do, which kind of Todd mentioned already. The waters have been muddied with the sort of population-based meta-analysis in JAMA, and then the India studies, which really outcome was the same as the ALPS trial. So we had a robust discussion in our division, and then based on everything and also the hypoglycemia and potential for those epigenetic changes, possibility of that head circumference being low and neurobehavioral outcomes, we decided not to. Let me touch on the other aspect, right? The other extreme of gestational age. There also, when we talk about 21 weeks, 5 days, or 20 weeks, we have to we have to really think about the same thing, like biological plausibility. That where is this steroid working on? So do we even have enough type 2 pneumocytes to stimulate? Because that's the main respiratory morbidity that we're talking about. And so what's your take on that? Like, how much of lung development can be stimulated at that gestational age, and the intact outcome is anyways, it's because of the IVH and the neck and everything else, the outcomes are not great. So what we do here, I know you were saying that it's a nice discussion to have. We do shared decision making at that point. We do it with the NICHD periviability calculator, right? Like, and if the patient wants everything done at 22 and 0, then in those cases, we do give steroids. We do offer steroids, but that's not something that is recommended. And that mainly came from, actually, I reviewed the neonatal data in our institution from 2017 to now. There has been no survivor, zero survival, when we have intervened and given everything, like done everything at that 22 and 0 gestation. Okay, so that's just,
Correct.
It's not published, but that's our institutional data. So we have to think about things.
That's important too, because there's also, I think, a lot of other caveats. We did have a patient. I think at least there's enough data to suggest that there could be benefit to steroids at that gestational age. So at least it should be discussed. And I agree with you in terms of when you're thinking about mechanism, lungs, but also it really at that gestational age really reduce the risk of a number of other outcomes, IVH, neck, overall survival. We had a patient that came at 21 and 6 PPROM just recently. She's still admitted actually. Once we had NICU involved. The birth weight, the estimated fetal weight was about 430 grams, I think, or 450 grams. And after discussion, et cetera, opted for administration. And even there's some recent evidence to suggest magnesium is even effective as early as 22 weeks. The challenge, though, now what's interesting is thinking about mode of delivery, by the way, because there's also, if you look at those studies that I cited related to, steroids at 22 weeks, in one of the JAMA articles, the rate of C-section was 44% among those that got steroids. I've never done a C-section at 22 and 0. And so we had a whole discussion at our division meeting. So I think there's so many factors that get incorporated. If you're going to do a C-section, how technically challenging. It's not just the steroids alone that you see in that preterm birth calculator that can really help. It's also if you're having a C-section, if the patient's obese, if it's a very small estimated fetal weight, there's so many different factors. So I think at least we know that steroids can be effective, but the counseling is super important because it's not just steroids that is going to be as effective as the intervention that will help. And it's not just also neonatal support from the pediatricians. It's also mode of delivery, it's magnesium. There's a lot of different factors.
Totally agree. And the long-term harm that you create with those 22-week C-sections, for the life of that patient. But who knew after that Liggins paper came out, like that we will be debating this 50 years on and still not have a consensus. But outstanding talk. Thank you.
I see that Dr. Lin has her hand up.
Hi there, my name is Ruby. I'm a third-year MFM fellow here. Is there a certain, I know there are a lot of studies looking at expanding the application of antenatal steroids. Like, for example, in the UK, they give steroids for a planned C-section at term. In your mind, are there certain populations that you would not give antenatal steroids to that you think is not a good idea?
Yeah. So, thinking about, in term, I know that's been studied. I don't think there's enough evidence to support its use in term patients. I think preterm, we're pretty strict with our adherence to the ALPS protocol. So if someone had received late preterm steroids, if someone had been exposed to steroids prior to 34 weeks and is now between 34 to 36 and 6, we don't give it a dose. We don't give it to patients with pregestational diabetes. I mentioned that now multiple gestations. controversial, less than 12 hours. So if someone comes in with severe preeclampsia as a repeat C-section at 35 and 5, and they're going to be going to the OR in 6 hours, I don't give steroids to that because I don't think there's enough data, but I know that hopefully that will be an emerging topic. So I think, and then, less than 34 weeks, I've had cases at North Shore LIJ where we gave steroids to a type 1 diabetic who got DKA. And so, you have to be really careful in those diabetics that patients with diabetes that have really poor control. So I would avoid late preterm in those who had already been exposed to it and have pregestational diabetes. And then prior to 34 weeks, those with really poorly controlled diabetes.
Thank you. It's just so interesting as I was listening to your talk about how like the ALPS trial improved, like we know the TTN, but there's data that shows that, for example, at term C-section, it was improvement in like the respiratory admission to NICU. And it's just interesting how different countries select different data and follow different guidelines.
Yeah. Yeah, certainly. I mean, this is, we even at SMFM, I always enjoy speaking about it with colleagues from around the world, because there's certainly significant differences in practices. And there are certainly a number of people who think that CPAP for 12 hours or a little bit of TTN, they would say like a little bit of TTN is really nothing compared to potential, long-term impact that people are concerned about.
Well, Dr. Gulersen, thank you so much for this talk this morning.
Yeah, thank you so much. Thanks for having me. It was really a pleasure. And by the way, I'll put my email address in the chat if anyone is interested. I'm always happy to collaborate or whatnot. It'd be great.
Thank you so much. All right, so we're going to have to end it here. I hope everyone has a safe and productive day. Thank you.